The unmet clinical needs to treat patients with PVCs and VT are different. One is that we need ways to differentiate between patients in whom PVCs are the main problem, and then they may develop a ventricular myocardium problem secondary to PVCs, and this is totally different from patients in whom PVCs are a secondary problem to the myocardium problem. And sometimes this is tough to differentiate, because in the first scenario we have to fight to get rid of PVCs. But in the second one, the benefits of getting rid of these PVCs by invasive method like ablation are not so clear. So we need additional tools to try to make the division of these two types of patients more evident. In addition to that, we still need to improve our mapping of these PVCs. Sometimes it's really challenging to guess from where these PVCs are coming from, especially with non-invasive techniques. And this is important in order to decide whether to send this patient for an ablation procedure, or once you have decided to send the patient for ablation procedure, to plan your strategy to ablate this problem. Finally, still if you have submitted your patient for ablation, we know that some of them can be easily ablated with present technologies, but some of them this is not the case, because the focus is coming from the epicardium, or is coming from the intramyocardium layer, or is close to the coronary arteries. So we need new tools to address the problem of these patients. The success rate in order to avoid recurrences with drugs is not very high. For example, we know that treating patients with drug avoid significant recurrences, let's say more than 90% of load of PVCs in less than 10% of patients. If we are less strict and we only we allow reduction of burden of just 80%, is only achieved in 20% of patients. So drugs are easy to treat patients with drugs, but probably are not the best tool. Ablation is a different story, and there has been recent papers comparing ablation and drugs. And one of them, for example, compare beta blockers and ablation for patients with PVCs coming from the outflow tract, and at 1 year follow-up, only 20% of patients, less than 20% in fact, had recurrences in the ablation arm. And this was strikingly different in the beta blocker arm, that 90% of patients had recurrences. So I think that this explains why ablation is considered more and more often in the treatment of these patients nowadays.